Hi, I'm Dr. Kathleen Berkowitz, and I thank you for joining this webinar that we will be speaking about the treatment of gestational diabetes. First, a disclaimer, this is a resource. It doesn't define the standard of care in California. Please feel that the guidelines can be adapted and the resources adapted based on your local facility's level of care and what your patient population needs. The recommendations are based from California Diabetes in Pregnancy Program Sweet Success Guidelines and the most updated guidelines from the American Diabetes Association and American College of OB/GYN. I want to let you know I have no conflicts to disclose for this lecture. So for those who got to see the prior lecture on diagnosis and initial management of gestational diabetes, one of the things I referenced is that signposts and directions are not always clear. And so here you can see we've come to a signpost and a crossroads, and this one is pretty obvious. I'm taking a left and I'm going on to Tranquil Trail. I'm not going on to Bloody Basin. But as we get into the treatment of gestational diabetes, you'll see that these crossroads and these choices are obviously not as clear. So without further ado, let us go ahead and sort of jump off into the woods, and I will show you some of the trail posts that we're going to be using for objectives for this lecture. We would like to understand the goals for managing a pregnancy complicated by gestational diabetes, what the complications both to mom and baby are associated with this diagnosis. We will review what is known about blood glucose targets and ranges. We'd like to be able to understand the therapy goals and the potential complications associated with the diagnosis of gestational diabetes in each trimester. I do want to spend some time on each of the landmark studies, which are going to inform our best practices concerning why we say certain targets will give us optimal outcomes for glucose control. We're going to talk about the use of oral agents and insulin therapy, as that management paradigm has changed a lot recently. Try and predict which patients are going to do well and which are going to fail their current therapeutic regimen and require changes. We're going to talk about examples of oral agent and insulin dosing regimens. And again, because these things have changed a lot, there are differing organizations who have differing sets of guidelines. So American Diabetes Association and ACOG have one set. Society for Maternal Fetal Medicine has another set, which we will go over. We'll talk about the cases where hospitalization may be indicated for glucose control. And then we're going to talk a little bit about glycemic control in labor and immediately after delivery. So let me bring everyone up to date on where we stand after the end of the last lecture. So you've correctly screened your patient based on your local protocol, and you have correctly diagnosed that she has gestational diabetes. We got to the point where we've provided her with education and support concerning diet, exercise, and home glucose monitoring recommendations. You've set her loose to do this for a week or two, and now you have a follow-up visit with her and now need to determine if her glucose control is optimal. So that's the point at which I want to pick up the care for the patient that we finished discussing with in the last webinar. Again, it's important to remember the why. Why are we doing these things? What are the goals of managing diabetes in pregnancy? The bottom line goals are you want a healthy mom and a healthy baby, which means for mom, you prevent the complications that could occur during pregnancy, and if possible, you raise her awareness of what her possible long-term medical complications can be and help her develop strategies to avoid those. From a baby's point of view, again, you want to be born at term and you'd like to be born with all your bones intact. You do also want to prevent the long-term medical complications such as childhood obesity and maybe even early onset diabetes. So those are stretch goals. The complications that can occur with a diagnosis of diabetes in pregnancy. Increased rates for miscarriage are not as commonly seen in the gestational diabetic. They can be seen in patients who had overt diabetes who were not diagnosed prior to their first prenatal visit. So I am including them as a risk factor here, even though technically we are talking about treating gestational diabetes. Increased risk for urinary tract infections, for preterm labor, for the development of preeclampsia, and for the need for cesarean delivery. From the fetus's point of view, increased risk, again, for malformation, usually associated with poor first trimester control, stillbirth, birth trauma, and the risk for neonatal metabolic complications as well. So those are the complications that we're trying to avoid. These are the issues that you will have discussed with the patient when you did her initial diagnosis. And now she's in front of you for the follow-up visit. Here's some of the things I want to have you look at from the patient's perspective as she's coming in to your office. First, she's afraid of this diagnosis. And this may be the first time in her life that she's been told she has a medical complication that could cause bad things to happen. So there is an underlying level of fear, which some people are dealing with well and some are not. Her family has now had a chance to put their input into what's going on, and they may be telling her things that are good, sound advice, and they may be things that are not consistent with management of diabetes during pregnancy. So those are issues that you need to address as well. You've asked her to do some hard things. You've asked her to change her diet, exercise habits, start home glucose monitoring. And there is, in all of us, resistance to change. What's her current state of knowledge? Is she confused about all these things that you talked to her about last week? What has she been able to do so far? And how does she think her efforts are working? One of the things that I try and do at this point, the first question I will ask a patient, I try and make as open-ended and non-judgmental as possible. So I avoid questions that focus on a specific part of management, such as, well, how many times did you check your sugars? That's not an open-ended question. I would prefer to see an open-ended sort of interview type question of, well, we talked about a lot of things last week. How do you think your week went? And then it opens her up to be able to say, well, this went well and this didn't. I'm afraid of this. I don't understand that. I think I'm doing a good job here. You'll get you'll elicit much more of what her challenges are if you will ask a non-judgmental, open-ended question. So I encourage that as the first thing that you ask her when she returns for this visit. You'll want to review with her once you've elicited her perspective. You'll want to review the goals of therapy that you talked about, because this is a signpost that she needs to be shown every single time she comes in. How's your weights doing? How's your activity doing? How's your diet? And let her know that the ultimate value that we're looking at, the glucose numbers, are a reflection of all facets of the care. So we have to pay attention to all of those things and not just the end result, which is the glucose number on the glucometer. Weight gain. Ideal weight gain for a patient whose body mass is over 30, which most of our patients with gestational diabetes fall into this category, if not even the higher BMI categories, 11 to 20 pounds for the entire pregnancy. Now, it is true that by the time you see her at 28 weeks, she may have already gained 25 pounds. You're not going to now tell her to lose 5 pounds, but you're going to try and manage the weight gain appropriately for the rest of the pregnancy. The earlier you see these patients and the earlier you have these discussions about ideal weight gain and nutrition, the more likely you are to be able to achieve those goals. But yes, quite a few of our patients will show up and they have already exceeded that goal. One of the other key strategies that we had talked about last time is that all patients need a team approach with a diabetes nurse educator, a dietitian, an experienced healthcare provider who can be an endocrinologist or an obstetrician or a maternal fetal medicine or a family medicine physician, working in coordination with the primary care MD, who is the OB, and a social worker. This is the ideal makeup of the team for your patient, And it is important that the team all have a unified view of what diagnosis is, what management is, and what support services are available. Again, we usually are starting all patients with diet, exercise, and home glucose monitoring after their initial diagnosis and letting that run for a week or two, and then having her come back to see how those results are going. This is also a good time to review with your patients that whatever family input has been confusing to her, because what's normal in pregnancy is much lower than when someone is not pregnant. And so for elderly patients who have type 2 diabetes, their family medicine physicians may be afraid of hypoglycemia, and they'll be running them a little higher on purpose. So it's important to let her know what is normal in pregnancy. These numbers here are from a lean group of women who do not have gestational diabetes, but this is what is normal in pregnancy for that group of patients. Patients with a higher BMI do have slightly higher of those values, but again, those overall are much lower than what you would expect for a patient who is type 2 diabetes and not pregnant. So this is where you help decide how much her family's input is actually relevant to her goals for control. Now, I want to acknowledge there is a bit of a controversy on what is a rational goal for glycemic control. And when we start to talk about the HAPO, the Hyperglycemia and Pregnancy Outcomes study, we'll talk about how difficult it is to come up with a threshold. But there are essentially, in my clinical opinion, 3 categories of patients. Those whose fasting and post-meal values are in a range where the majority of studies and the majority of clinicians know that there are low complication rates and they're doing fine on diet and exercise. There is a group whose values are consistently in a range where the complication rates are increased, and pretty much every clinician is going to agree that that patient needs to start on medication. And then there's this battleground group where there are some studies that show benefits to tighter control and some that show no benefits. And so as we talk now about the hyperglycemia and pregnancy outcomes study, I want to show you how those rates of complications really increase in a continuous fashion, which makes it very hard to define any one specific number for control. Most people will agree if your fastings are under 90 and your after-meal sugars are less than 120, you're doing fine. American Diabetes Association goals are less than 95 milligrams per deciliter on the fastings. And for ADA, they're using 140 for 1 hour and 120 milligrams per deciliter for 2-hour values. I will tell you that there are clinicians who do want to run it tighter, and I will show you that from the HAPO study in just a second. Everyone is going to agree if your fastings are consistently over 105 milligrams per deciliter, post-meals over 140, 1 hour or 2 hour, those patients need better control. So the battleground patients are really when your fastings are between 90 and 105, your post-meals are 120 and 140, and this is where you and your team need to decide where on this battleground you want to set the line for starting therapy with insulin, and where you're going to be in agreement that she can continue on diet and exercise. Again, we'll be talking about HAPO study in just a minute. Now, I'm putting a slide for first trimester complications in here, not because gestational diabetes is diagnosed very often in the first trimester, but because the fact that we are often screening high-risk populations will uncover patients who had impaired glucose tolerance and now have an early diagnosis of gestational diabetes, or it will uncover the overt diabetic who did not know that she was pregnant. So I do want to talk a little bit about first trimester complications and goals of therapy for that category of patient. There is an increased risk for miscarriage, which is associated with glycemic control. And unfortunately, that risk exists from the minute of conception. And so a lot of the malformations can occur even prior to when she finds out that her pregnancy test is positive. So when there's an extremely early pregnancy that is identified in the setting of extremely poor control, this is a situation we'll talk about as somebody who might need hospitalization with an insulin drip. Another issue is hyperemesis gravidarum and the onset of ketosis, which happens a lot more quickly for the pregnant patient than it does for the non-pregnant patient. And so they need to be informed that if they are unable to keep food down or liquids down, they should present for intensified care sooner rather than later, not try and deal with that for 2, 3, or 7 days at home. This is where people really need a lot of education concerning the diet therapy and how important it is to have a consistent diet and why we have these new glycemic targets. Finally, for those who do turn out to be overt diabetics, try and establish what their diabetic class is. Once you get into the second trimester, the patient's insulin resistance begins to increase and hyperglycemia becomes more frequent. Preventing hyperglycemia in that late second trimester, early third trimester time will help control the rate at which fat and adipose tissue is being laid down on the fetus and will decrease the macrosomia rates that are noticed at birth. In order to do this most effectively, you really do need to use postprandial values. Postprandial values are linked to better glycemic control and decreased macrosomia rates. Obviously, in pregnancy, you have progesterone slowing the passage of urine through the urinary tract. You have an increased amount of sugar in that urinary tract, which is a very nice setup for the occurrence of a urinary tract infection, which, if it ascends to the kidneys, can be associated with both preterm labor and acute respiratory distress syndrome. This is the point at which you need to continue your patient's education, and if you can, be very proactive about telling her, starting around 20, 22 weeks, her insulin requirements are going to increase. It doesn't matter if she's doing an absolutely perfect job on diet and on exercise. It's not her fault that her numbers are going up. It's her placenta's fault, which is producing human placental lactogen and increasing her insulin resistance needs. So be proactive, let her know that that's going to occur, and then it will be less scary for her when it does start to happen. Late second, early third trimester insulin increases easily triple in many patients. Most patients will experience at least a need to double their insulin intake during this time. And they do need to be seen more frequently, either through chart support, telephone calls, face-to-face visits. They do need increased support during that time. Here's a study that came out of UC Irvine. It is now close to 25 years old, but it was a landmark study looking at patients who had gestational diabetes. One group was randomized to preprandial monitoring and basing their insulin doses on that. The other group was randomized to postprandial. And you can see that for the group that had the post-meal monitoring, the large for gestational age rate was a quarter of what it was for the other group. The shoulder dystocia rate was significantly decreased from 18 to 3%. And any of us who have been dealt a shoulder dystocia delivery would love to see as few of those in the future as possible. And the babies had less neonatal hypoglycemia, which in many cases will lead to fewer ICU admits. So this really showed the importance of postprandial monitoring, which allows you to gauge how much insulin resistance there is in determining what your patient's insulin needs are. Once you get into the third trimester, the thing that, of course, scares most people is stillbirth and preventing stillbirth. However, with good glycemic control, good antepartum testing, and surveillance for preeclampsia, the stillbirth rates for gestational diabetes are very low. Again, best way to manage that, use your fastings and your postprandial values for that. Because one of the reasons that the stillbirth may occur is a large baby with a large oxygen requirement, and then the placenta begins to age a bit, and all of a sudden the fetus is no longer able to achieve the oxygen levels that it needs to because of that aging placenta, and that's where you get a sudden stillbirth. If you prevent macrosomia, your stillbirth rates will be lower. And so that's an important thing to do. You, at this point, want to be having as close to ideal control as possible, because good control in the third trimester leads to lower rates of neonatal complications such as hypoglycemia and an enhanced likelihood that your mom and baby are going to be able to leave the hospital together. Here are some stillbirth rates. This is type 1 and type 2 diabetes, and this is a study out of Great Britain looking at type 1 and type 2 diabetics, and you can see the type 1 diabetics had much higher stillbirth rates than even the type 2. So as your disease worsens, the risk for stillbirth increases. In the United States, our baseline stillbirth rate, depending on the subpopulation and what area of the country you're in, are anywhere in the 3 to 10 per thousand range for the women in the general population. For women in the diabetic population, there are numbers all over the place, from 17 to 33 per thousand. But again, those really can be stratified into those with poor control and large babies have higher stillbirth rates than the well-controlled gestational diabetic with a normally grown baby. Her stillbirth rate is not significantly increased prior to term. Going back to the other outcomes that can separate mom and baby, all of those birth weight, cesarean section rate, neonatal hypoglycemia rates, and this is where we're going to start talking about the hyperglycemia and pregnancy outcome study. This was 25,000 women, 15 centers, 9 countries, and the group was women whose fastings were less than 105 milligrams per deciliter and whose 2 hours were under 200. So these are patients who have what we would consider to be mild gestational diabetes. Some of these will respond well to diet. Some of these will need medication. They looked at the primary outcomes, which they considered as birth weight, C-section rate, and rates of neonatal hypoglycemia. And then they looked at some secondary outcomes, which are a little rarer, such as preterm birth, shoulder dystocia, NICU admit, which we'll talk about more in a minute, and again, the occurrence of preeclampsia. So in this study, here's why we have a battleground. You can see that the green, red, and yellow lines representing birth weight, neonatal hypoglycemia, and primary cesarean section rates have gradual increases. There is no one point for most of those complications where you see a significant uptick until you get to the point where your fasting sugars were over 100. If you look at that range between 90 and 94, rates of neonatal hypoglycemia are pretty much standard. Slight increase in birth weight, and cesarean section rates are nearly flat in this range. And this is why that fasting range of 90 to 95 is a battleground for a lot of people, because you really don't see a lot of change in those primary outcomes measured by HAPO in those. Looking at the odds ratio, for every 1 standard deviation increase in the glucose level, you saw these incremental increases in preterm delivery, preeclampsia, NICU admit, shoulder dystocia. So wherever I have them in red, you have significant increases as you move up that ladder. I do want to see if I can go back that slide, though, because I want to show you. There were people in this group, her fastings were less than 75. And those are their complication rates. These are patients who were in the study, diagnosed as gestational diabetes, but who were really under excellent control. And so even they, at those levels, still have complication rates. It is impossible to get that complication rate to 0. You can get it lower. Again, the other important thing about these patients is they were not treated with medications. These were patients who were just fastings less than 105, 2 hours less than 200, and they got diet instruction and really untreated otherwise. And then you see these gradual increases, which is why you have really no clinical consensus on when that increase becomes significant from a clinical point of view. Another very big landmark study, the Australian Carbohydrate Intolerance Study, looked at a different group of patients. This was 1,000 women. You can see that their fastings were higher than in the HAPO study. This was a very difficult study to enroll in. This took 10 years and 2 countries to achieve their enrollment goal of 1,000 women. Their primary outcomes were death within 30 days of delivery, shoulder dystocia, birth trauma, and then they also had a look at maternal psychologic and anxiety and depression scores because of the stress of being treated for a chronic disease. Their secondary outcomes were gestational age at birth, so looking at preterm birth, birth weight, and rates of preeclampsia. So those secondary outcomes, some of them were quite similar to what HAPO looked at. And here's what the Australian Carbohydrate Intolerance Study showed. For patients who were randomized to insulin versus routine care, the complication rates were much higher for the patients with perinatal, with routine care only. The shoulder dystocia rates were higher. Now look at the NICU admit rates, 71 and 61%. When you look at some of the other landmark studies, you will see NICU admit rates of 20%, 17%. And so NICU admit in some areas is programmatic, meaning if a patient has a diagnosis of gestational diabetes, her baby will be admitted to the NICU for at least a 24-hour period of observation. So simple NICU admit rates are not really good surrogates for neonatal complications because of these programmatic decisions that big systems make. This is why when I look at these studies, I encourage you to look at things like macrosomia, hypoglycemia, hypothermia, treatment for hyperbilirubinemia, the occurrence of preeclampsia, something that's a firmer endpoint than just a NICU admission. But again, you can see with the study that we didn't see very much of a difference in cesarean section rates. Preeclampsia rates were much higher for those that had care under the routine regimen. And induction of labor was higher for those that were on insulin. Again, the more you're doing to a patient, the more you worry about her, the more likely you are to want to manage her delivery process. This is another landmark study. This is the United States Preventative Services Task Force, the USPSTF. This was a citations trial. They looked at 14,000 citations. They found 5 good randomized control trials, 2 cohort trials that were sufficiently strong to allow for a meta-analysis. There were still variations in diagnosis with each of the randomized control trials, and there were variations in treatment criteria as well. But there was still more similarity in those trials than there were in the cohort trials. So when I went to pull out data for you on this, I chose to look at what the randomized control trials were showing based on shoulder dystocia, neonatal hypoglycemia, birth weight, and preeclampsia rates there. And so what you can see there is that treatment very definitely decreased the risk for shoulder dystocia, decreased the risk for a large baby, but really didn't do a whole lot to prevent neonatal hypoglycemia or preeclampsia. When you look at the overall group of data and look at the strength of evidence for benefits and harms of treating gestational diabetes, preeclampsia was moderately treated, favoring treatment. Shoulder dystocia favored treatment. There was a low strength of evidence, but favored treatment for prevention of neonatal hypoglycemia when you added those cohort studies back in. So this is another reason why we're using the goals that we're using. Another landmark study, this was treating mild gestational diabetes in the 3rd trimester. This is nearly 1,000 patients. And you can see that these patients, their fastings were less than 95, but they did have 2 or 3 abnormal results on the 1, 2, and the 3-hour test. And they were randomized to usual prenatal care or to diet, exercise, home glucose monitoring. And then they looked at a composite morbidity rate for this, which included stillbirth, birth trauma, and neonatal death. Bunch of things all together. Obviously, if you lump together a bunch of rarer outcomes, you're more likely to be able to see differences in composite morbidity rates than in each one of those separate categories. And this was Mark Landon's data, again, in 2009. And so his treatment and control groups are there in lime green. I have the data where there was evidence for benefit for treatment, and you'll see those rates there. Again, NICU rates in that study were 9 and 11%, not 61 and 71. So this just shows you how the programmatic use of a protocol for NICU admit can affect your study outcomes. And that's why I choose not to use that so much when I'm talking to patients, because you need to know what your local issues are going to be. Now, once everybody's agreed that your patient needs to start medical therapy, this is where we come up with our next controversy. I've been doing this for a while, and I've moved from the era where everybody got insulin to the era where everybody got oral agents, back to the era where everyone is being recommended for insulin. So I'm going to give you a little bit of perspective of each one of those historic epochs there. Oral agents, up until about 2015, when the things began to change, there was great support for use of oral agents as first-line therapy. In 2018, American College of OBGYN recognized the fact that there isn't a whole lot of data on long-term outcomes based on exposing the fetus and the fetal pancreas to these oral agents in the in utero environment. And they backed off a lot on allowing these oral agents to be considered as first-line therapy. So that change was really just last year. Insulin, using ACOG and ADA criteria, is the preferred agent. Orals should be reserved for women who are unwilling or unable to take insulin. And so insulin is now back to being the primary agent. Now, again, let's go back historically to what some of the impetus was for using the oral agents. Way easier to use. Therefore, if it's easier to use, maybe your patients will be more compliant. Definitely less expensive. I can send you to any one of a number of big box stores, and you can get a generic for either a sulfonylurea or for metformin for $5 for a month. And insulin per vial now is $75, $125, $150 a vial. The problem with it was that it could lull the patients and providers into a false sense of security about glucose control, and there is an underrepresented risk for hypoglycemia. So it was treated a bit more cavalierly. Here, take this pill. And so you would see, because there was less education of the patient about hypoglycemia and glucose control, the follow-ups tended not to be quite as clinically extensive as the patients who got insulin for most clinical situations that I observed. Insulin, again, is expensive, and the fancier your insulin, the higher the price tag. I will point out that a lot of the old standbys, like NPH and regular, really work nearly as well as some of these very expensive insulins. And if they are more available and that's the only thing your patient can afford, consider them rather than the more expensive, newer types. It does require multiple daily injections, and that need to inject may decrease your compliance. But again, insulin is now back to being the primary agent that is recommended. None of these agents are associated with an increased risk for birth defects. Most of that risk occurs in the first trimester. The first trimester risk is associated with your glycemic control. If you're under good control, it really doesn't matter which of those agents you're on. Again, that's a different question than what happens to the fetal pancreas that's been exposed to these agents in the third trimester, because metformin and glyburide do both cross the placenta where insulin does not. So again, the we don't know as much about those long-term metabolic effects of that exposure to those oral agents. Another issue is if you start with an oral agent, you're probably going to have to switch to insulin at some point for a large number of patients. Depending on the study that you look for, and I have a few listed there, anywhere between 26 and 46% of women who start on metformin will need to switch to insulin because they have not been able to achieve glycemic control on metformin alone. Glyburide, those rates are lower, and so again, you would think that that might be a better agent, but it's got its issues as well. I like to always move back to clinical practicalities based on what I've seen for many years doing these consultations. If you have to send a patient out for consultation, you're going to make your diagnosis of gestational diabetes at 24 to 28 weeks. You're going to write a note to your office manager or your PA or your insurer authorization manager, send patient for consultation, start diet and exercise. Generally, that process takes a couple weeks. Then you're going to review the efficacy of an initial treatment a couple weeks after that. Before you know it, you're at 30 to 34 weeks. And so at this point, you really want to make sure that you are using an agent that is going to get you good control quickly. And that is where insulin has a better track record than the orals because of that risk for therapy failure. There is some data in trying to figure out who will fail therapy. So not huge studies, but they're there. Looking at early diagnosis of gestational diabetes. If you've got a very high glucose challenge test result or a lot of weight gain, those will predict eventual failure for glyburide. On average, though, patients who were started on insulin got there pretty quickly, within less than 2 weeks. If you failed glyburide and then got moved to insulin, it took up to 40 days to get you to goal limits. So clinically, the way I would recommend using glyburide or metformin either, because glyburide is not listed as an agent that should be even considered right now above metformin. Limit any of those orals to those that are identified in the third trimester, fastings that are in the 100, 110 milligram range. They're likely to do well if you start them on an oral. Again, ACOG and the ADA do not recommend starting oral agents. That is a different goal than the Society of Maternal Fetal Medicine has advocated, and we'll get to that in a minute. The other thing that I would really recommend doing when you're seeing your patient is you need to look at her glucose log and her meter. A couple weeks ago looked at a patient's meter, and she had imputed what she thought her glycemic numbers should be after a meal rather than actually checked her sugars. And she was doing that because the strips are expensive. So look at the meter and the glucose log and use that as a non-judgmental jump-off point to talk to your patient about what the goals are and why. And essentially what I tell patients is, I want truth. I'm not going to judge you as to whether it's a good job or a bad job. I just want to know what the truth is so I can help you get to where you need to be. Let her know that you're not going to be judgmental about what she's been able to achieve. Once you get those goals established, then you can sit down and start the review, because you really need to move from that objective data that she's giving you to a non-judgmental assessment of how well she's doing. If you do this in a non-judgmental fashion, you are going to be able to involve her in the buy-in that you're going to need to get any improvements that she needs to make. Now, we're going to talk a little bit about what therapies you're going to try and talk her into taking. Again, the oral agents that are out there are sulfonylureas like glyburide and then like metformin, which is a different class of agent, and then various insulin regimens. Clinically, I've seen all of these things used often. Twice a day mix of NPH and regular in the morning before breakfast, a dose of regular at dinner, NPH either at dinner or at bedtime, 3 times a day, Humulog or another short-acting insulin before meals with NPH at night. I've seen all sorts of regimens used. I've seen Lantus in the mix. So know that there are several regimens out there. Know that your group, your team needs to pick one or two that you find your patients can understand and use, because switching her from regimen to regimen is going to increase her confusion and lengthen the time until she is able to achieve control. Again, the teratogenic potential, it's really more related to your glucose control at the time of conception. Other concerns about hypoglycemic medications, the development of lactic acidosis. So these agents are not for patients who have type 1 diabetes. These agents are not for patients in the late stages of type 2 diabetes, and they are not for patients who have renal disease. Again, concerns exist about how long it takes to get to appropriate glycemic control, and then there are issues for using them for breastfeeding afterwards. So you can see there are a lot of drawbacks to using the oral hypoglycemics. For metformin specifically, it's a biguanide. It decreases hepatic glucose production, acting directly on the liver, and it decreases glucose absorption as well, and increases peripheral tissue uptake. So those effects in the maternal circulation are also mirrored by the processes that need to take place for the fetus as well. Side effects for mom include GI upset and loose stools, and that can be in as many as 5 to 10% of patients. Metformin stacked up against insulin, you get less weight gain, you get a little bit less hypertension, you get a little less neonatal hypoglycemia, at least in these two studies I'm quoting here, and a little bit lower gestational age at birth. Long-term outcomes, very similar neurodevelopmental outcomes, and again, trying to speak to the long-term issues, similar body fat percentages for the toddlers. That should reflect what is a possible risk for childhood obesity. For the oral sulfonylureas, it increases pancreatic insulin secretion. Think of it as putting an overdrive on your pancreas. Your pancreas, in the situation of gestational diabetes, is already pouring out large amounts of insulin, trying to overcome that insulin resistance, and the sulfonylureas essentially goose that secretion even higher. Fetal serum levels are about 70% of maternal serum levels for that. It does stimulate beta cell insulin in both the basal state and the postprandial state, decreases the fasting hyperglycemia very well, but again, it's going to be most effective in patients who have either gestational diabetes or early in their diagnosis of type 2 diabetes, because you do need good beta cell reserve for the sulfonylureas to be effective. And again, don't use them in patients with renal impairment. Decreases the risk for thrombosis, improves your lipid profile a little bit, but overall, no decrease in the risk for hypertension or stroke. So those things are outside of pregnancy. The one big study that was that sort of started the ball rolling for Glyburide use in pregnancy was Dr. Langer's study in 2000, 400 women, achievement of glycemic control on Glyburide alone, and he looked at the cord insulin levels, the macrosomia rates, the C-section, and the neonatal hypoglycemia rates. They had average glucoses pretty close to ideal prior to treatment, and he found that Glyburide had not much effect on macrosomia rate, did not increase the NICU admission rate, and did not really increase the rate for neonatal hypoglycemia. Most of his patients met their desired glycemic targets, and again, there was no measurable fetal cord blood Glyburide noted. On the other hand, most of those women had not had a dose of Glyburide for at least 24 hours before they delivered either. So you wouldn't expect the fetal cord blood levels to be that high. But that study, you can see, look what it did to clinical practice. We went from fewer than 10% of patients on sulfonylureas in 2001 to, by 2010, a decade later, nearly 60% of the patients were being treated primarily with Glyburide. And that continued all the way through 2011. Now, I'm sure that trend has reversed just as markedly, although I haven't seen any studies on that. Here is a study, a couple of studies looking at metformin and glyburide to insulin. Glyburide in some of these studies was associated with more frequent macrosomia, more frequent neonatal hypoglycemia. I will tell you that it was my clinical experience that based on the babies I tracked from the patients I consulted on, I do think that I saw more neonatal hypoglycemia when my patients were on glyburide than when they were on insulin or metformin. So my clinical senses match what this study shows. Metformin had the lowest rates of neonatal hypoglycemia in NICU admit. So overall, quote unquote, metformin was quote best, with metformin and insulin second best, glyburide inferior to both agents in prevention of maternal and neonatal complications. And that's in an article that published in the British Medical Journal in 2017. A good article, again, one of our landmarks. So again, Society for Maternal Fetal Medicine had come out with a position statement shortly after ACOG put their recommendations up for insulin as first line, saying that there were situations where they felt metformin was equivalent first-line agent. So you do have controversy within the communities as to what is an appropriate first-line or second-line agent. With SMFM saying metformin can be used, ACOG and ADA very specifically saying insulin is your first-line agent. If you're going to start someone on metformin, you need baseline serum creatinine before you start. There's the dose. There's your maximum effective dose. And again, glyburide is now considered an inferior agent to either metformin or insulin, but those are the doses that are there. Insulin starting doses, anywhere between 0.7 and 1 units per kilogram daily, divided up into a combination of long-acting or intermediate and short-acting insulin. My favorites are NPH as opposed to the longer-acting, such as Lantus, and I will use either regular or Humulog depending on whatever my patient's insurer will cover, although most people are trying to use also the shorter-acting insulins. I will individualize my dosing once I know what my patient's glycemic pattern is. Does she work at nights? Does she get a snack in the afternoon? Does she work a split shift? Does she work 24-hour shift and then 24 off? So those are the things that I'll look at in my patient's life that I'll use to individualize my insulin dosing. Again, short-acting analogs such as Lispro and Aspart generally are preferred over regular insulin because they have a more rapid onset. You don't have to wait 30 minutes before eating. Again, I'm old and I like NPH, but you can use Glargine or Detmar for the longer-acting coverage. I tend to find that they really hang around too long and increase the risk for hypoglycemia, but they are certainly used very widely. So again, my personal preference, use what your team feels is appropriate. There is something that I refer to as the low-tech insulin pump, where instead of getting an insulin pump, you get short-acting insulin prior to each meal, and then you get the intermediate or long-acting at bedtime. That's essentially what I'm using for most of my gestational diabetics and my type 2s. A lot of my type 1s are on pumps, real pumps, rather than my low-tech version of a pump. Again, I will personalize it to either a twice a day, 3 times a day, or a 4-time-a-day regimen, depending on what she's able to do at work, when I feel she's going to be driving, and when I see her greatest risks for hypoglycemia to be. If she can't take insulin at work because she doesn't have access to a refrigerator, then you really do need to make sure that her lunchtime is relatively stable and give her a combination of NPH and regular or NPH and Lispro at breakfast. Does she know how to mix insulin types? These are things that you're going to have to go over with her as well. Here's an example of how you start dosing. So taking that 0.7 to 1 units per kilogram, and that's kilogram of current weight, let's say you've got, that means you need 60 units. Give 2/3 of that before breakfast, that's 40. Break that up into intermediate and rapid acting. Again, this is if you're going to use a TID regimen. And then use the other third at night, breaking it up in a dose of rapid before dinner and half of it before bedtime. Please note that if you look at that, almost every patient is going to end up with something like 20 and 10 in the morning, of 20 of MPH, 10 of regular or Humulog in the morning, 10 before dinner of the short-acting, and 10 of MPH or longer-acting at bedtime. My clinical advice in yellow is consider starting it a little lower than that, because my experience has been if your patient becomes hypoglycemic in that first week on therapy, it is very hard to convince her to up her insulin dose, because that experience of hypoglycemia is so scary for many patients. So I consider that first week of therapy what I call their training wheels week. QID dosing, again, what you're going to do is you're going to divide up the 20% as either the intermediate or long-acting, and then you're going to take the other 80% and give equivalent amounts of rapid-acting before each meal. I'm just giving these as examples. I do individualize that pre-meal dosing. Again, the gold is sort of my clinical opinions based on what her meal qualities are. So if she has a very light lunch, I might be individualizing that pre-meal dosing as lower. And again, I consider starting at around 10% less and giving them what I call the training wheel week. Here's the SMFM advice on medication that I've been referencing, and this came out in 2018. For women with gestational diabetes in which hyperglycemia cannot be adequately controlled with medical nutrition therapy, metformin is a reasonable and safe first-line pharmacologic alternative to insulin, recognizing that 1/2 of women will still require insulin to achieve glycemic control. Again, this was published in direct reaction to the publications from the American Diabetes Association and the American College of OBGYN. So recognize that there is a controversy in that, but discuss it thoroughly within your team. I would say that the pendulum has definitely swung back clinically to most women starting on insulin. And I do think, especially since metformin does have such high failure rates, that I prefer insulin as a first-line therapy as well. Here's ACOG's advice. Level A recommendation. Insulin is considered the first-line treatment. Level B recommendations, if you're having a patient who absolutely declines to do insulin therapy or they are unable to safely administer it, you can use metformin as a reasonable second-line choice. Neither metformin nor glyburide should be used as first-line agents, as both cross the placenta to the fetus. And that are, again, referencing the lack of long-term safety data because of that crossing of the placenta. This is American Diabetes Association advice. It also came out in 2018. Again, recommending insulin as the preferred medication for those who need a medication added to their diet and exercise therapy. Back to some clinical practicalities, which I always like to try and wrap up with. In the first trimester, we talked about the risks for nausea and vomiting, limiting your oral intake, and how you need to educate your patients on these new target glucose goals. Again, these patients are not usually gestational diabetics. They're either overt type 2s that you're just picking up early, or they had impaired glucose tolerance and did sort of cross the line over to a diagnosis of gestational diabetes early in pregnancy. But those would be my clinical pearls for things to watch out for in the first trimester. Second trimester, period of increased insulin. I'm sorry, that should say, well, the start of the second trimester is increased insulin sensitivity. So you'll see these patients at 12 to 15 weeks actually sometimes need less medication. And you'll especially see this for patients who had poor preconceptual control. You started working with them at 6 or 8 weeks. Now they're 12 to 14 weeks. And you've also improved their insulin sensitivity as you have used intensive insulin therapy. So the start of the second trimester is very different than the end of the second trimester, beginning of the third trimester, where insulin resistance is what is a hallmark of nearly every pregnancy between 24 and 28 weeks. I mean, this is why we do our testing for most patients at 24 to 28 weeks, because this is the time when insulin resistance increases are occurring. Evaluation of glucose control. Depends on my patient and depends on the stage of pregnancy she's at and how well she's doing. I may be in contact with her twice a week. I may be able to reach her once every 2 weeks. You can see how difficult it can be for a patient to come in twice a week to see you, then to see her nutritionist, dietitian, see her diabetes nurse educator, see her obstetrician, see her endocrinologist, and though, by the way, take care of her family and work at the same time. So the more areas where you can increase communication to voicemails, texts, electronic record notifications, MyChart modalities, apps, any way that you can manage to increase the communication to other facets of her life rather than you're simply relying on your face-to-face meetings will improve your ability to see her achieve good control. Now, hospitalization and when do I bring a patient in? Not that often. When the patient needs insulin right away and can't learn administration as an outpatient or has physical or insurance barriers or social barriers to even getting insulin, that's a patient I will probably hospitalize for a very tightly controlled set of goals. The goals being she learns how to do her insulin, she knows how to manage hypoglycemia, and I can get her a meter and I can get her into a follow-up plan. Those are my goals, not let's get her under perfect control before she goes home, because that goal can take 5 to 7 days. When a patient is got a significant clinical concern for DKA or for some life-threatening events of hypoglycemia, she needs to be in the hospital. And those conditions must be resolved before I consider her as a patient I would be happy discharging. When there is clinical concern for significant obstetric complications, what I'm referring to here is the patient who is at 26 weeks with pyelonephritis and shortness of breath. That's a patient who is also requiring hospitalization. The patient whose flu has now turned into pneumonia and is unable to keep her temperature down at home, that's a patient who I would consider bringing in for hospitalization. I'm sorry, I'm going back to slideshow mode, hit the wrong button. Hospitalization for glucose control is a different issue because the artificial control of the hospital environment doesn't allow, it may teach her what diet choices are, but it won't necessarily give her the skills to make those diet choices at home. So you'll be able to establish control while she's in the hospital, but you send her home, she's got the same diet, and you're right back where you started, and your control is no better than it was before you put her in the hospital. I would probably recommend, if you have a type 1 diabetic patient, again, that's not the gestational diabetic, or a patient with extremely wide clinical variation in glucose values, that's a patient you might want to hospitalize. And again, the new onset gestational diabetic with poor control, with knowledge or psychosocial barriers to starting insulin would be one of the indications I would have for starting insulin in a hospital setting. Again, these other situations, pyelonephritis, flu, GI syndromes, hyperemesis, unable to keep orals down, the rare psychosocial cases where you've got deliberate insulin misuse, or where there is consistent food insecurity, and I'm going to be able to overcome that using my social worker and a short period of hospitalization. Again, preterm labor, preeclampsia, planned administration of betamethasone for a patient who is insulin dependent or under poor control, or one who's got problems with fetal heart rate and antepartum surveillance. Those are patients I would bring in for glucose control as well. When your diabetic patient is being admitted for labor, a significant number of these patients are scheduled for an induced labor at 39 to 40 weeks. I like to see those scheduled in the morning so that they get to eat their breakfast and then come in the morning. Prolonged inductions do have higher failure rates and have been associated with increased risks for neonatal jaundice and maternal ketosis, so I try and avoid prolonged inductions. Labor is like exercise. Exercise decreases your insulin requirements, and so does labor. So for most women, their insulin requirements are decreased during labor, which is good news, because it means that their blood sugars are usually in a more average range than when they were at home and not in labor. You do need to maintain adequate hydration to help avoid ketosis. In labor, you want to see numbers between 80 and 140. 80 and 125 are also goals. You do want to avoid ketosis, and because if you do those things, you will decrease the risk for the neonatal metabolic complications. There are so many algorithms out there, and I really want to stress that it is important to look at your local resources and your local capabilities before you decide that you want to train every nurse on labor and delivery on how to do an insulin drip. It's a very difficult proposition, and you may be using intermittent boluses of insulin in a situation where you don't have those resources and you don't have that level of familiarity with this as a frequent situation that you have to manage clinically. So it is a very local solution with many, many different approaches. So sort of to summarize, first you have to recognize the disease, assessing the risk factors for it. You have to screen at the appropriate time. We managed to cover those topics in the prior lecture. Team approach is key. Diet, exercise, and home glucose monitoring is started for everyone and is the hallmark and the linchpin of effective therapy. Very important to manage those things because you can give all the medication in the world. If you don't have consistent diet and exercise and consistent monitoring of response to those therapies, your medication needs are going to be unknowable. Oral or injectable, again, I do prefer insulin, but know that there is a controversy within the community as to whether metformin's role as a secondary or a primary agent is appropriate. Have your patients recognize those rational goals of therapy, and then clinically, I call it bonus points for your ability to raise her awareness of her long-term health risks and strategies to decrease those risks, such as long-term good diet habits. Studies have shown that if you are able to maintain a new habit for 6 to 12 weeks, you've probably made it a new key behavior. We have the opportunity in pregnancy to have our patients make these changes and make them stick for 6 to 12 weeks. So I do think that if you really spend a lot of time on that, educating your patient, you have a good opportunity to change what her long-term health risks can be. Postpartum, Dr. Diana Ramos is going to be doing the next webinar on postpartum care and testing following gestational diabetes diagnosis. Your insulin needs will significantly decrease immediately as soon as that placenta is out. And so patients with impaired glucose control or diabetes will also see significant decreases in insulin needs postpartum. I generally, for patients who've had gestational diabetes, which has been well controlled, and I have a very low expectation that they actually have overt type 2 diabetes, I will stop monitoring their sugars in the immediate postpartum period. Other patients may need more control and more observation, and for more guidance in this, I will refer you to the next lecture by Dr. Diana Ramos. Thank you for your attention.